Dear colleagues, our lecture devoted on hereditary skin disease, part 2, keratoderma. Hereditary keratoderma. Palmo-plantar keratoderma, hand-foot keratosis, constitute a rather heterogeneous group of diseases of hereditary or acquired nature, in the clinical picture of which there are diffuse or focal thickening of the stratum corneum of the epidermis, mainly in the area of the palms and soles, less often in combination with keratosis of other localization. In European countries, the prevalence of keratoderma is 1 to 1,500. In Africa and Latin America, it is much lower. In the Russian Federation, the prevalence among the population is approximately 1 to 1,000 to 1 to 4,000 and 1 to 9,000. According to the origin of keratoderma, hereditary and acquired are distinguished. Hereditary keratoderma is caused by mutation in the genes encoding the formation of keratins and cell wall proteins. There are keratoderma with an autosomal dominant type of inheritance, TOS Unna-Keratoderma, epidermolytic keratoderma, Fonvinkel mutilating keratoderma, Bushke-Fischer keratoderma, Siemens keratoderma, an autosomal recessive form of keratoderma, especially Meleda disease, Papillon-Lefèvre keratoderma. Unna-Thost palmo-plantar keratoderma. The disease was described by Thost in 1880 and Unna in 1883. Dermatosis is inherited in autosomal dominant manner. Mutations have been found in the gene encoding type 9 keratin. All of these mutations are located in highly conserved region of helix 1a of the rod domain, which is believed to be related to the formation of dimers in intermediate filaments. It is characterized by diffuse excessive keratinization of the skin of the palm and sole, rarely on soles. The disease develops in the first or second year of life, beginning with a slightly thickening of the palms and soles. Horny layer are smooth yellowish. The peripheral edge of the horny layer is surrounded by a band of erythema. Patients are concerned about local hyperhidrosis. Deep cracks may form on the surface of the lesions. Nail growth is enhanced. They can be normal or thickened, deformed. Onychogryphosis may be observed. Over time, hyperkeratotic changes increase. Usually, other skin manifestations are not observed, but cases of combination with deafness, dominantly inherited ichthyosis, are described. In addition, cases of the development of hypergenitalism, thyroid dysfunction, clinodactyly, acanthosis nigricans, vitiligo, oligophrenia, deforming arthrosis of the interphalangeal joints, and deafness are described. On this slide, you could see the Unna-Thost palmo-plantar keratoderma. You could see the diffuse hyperkeratosis of the palms and soles. On this slide, you also could see the diffuse hyperkeratosis of the palms and soles. A number of authors have identified an X-ray picture of osteoporosis and atrophy of the phalanges, the presence of subluxation and deforming arthrosis of the interphalangeal joint of the hand and feet. In 2002, Kuster and others found epidermolytic hyperkeratosis on histology, which is characteristic of Werner epidermolytic keratoderma. Genetic testing revealed a mutation P.A162W in KRT9 in the parent family noted by Unna and Thost, and mutation of P.N1601 and KRT9 in the parent family noted by Werner. Both mutations were located on the same CoL1A segment and the beginning of the KRT9 central stem domain. On this slide, you could see the pathohistology feature of Unna-Thost keratoderma. Especially, you could see the phenomena of epidermolytic hyperkeratosis in the skin of the palm and sole, vacuole, and granular degeneration of cells of the granular layer and cell of the upper row of the stratum spinolosum of the epidermis. On this slide, you could see the common pathohistology feature of keratoderma. Especially in the 8th slide, you could see vacuolization of spiny layer keratinocytes in epidermolytic palmo-plantar keratoderma due to keratin 9 mutation. Instead, accumulation of tonofilament and cytolysis by electron microscopy. B slide, you could see the eosinophilic cytoplasm, but no obvious epidermolysis in inflammatory infiltrate in the congenital pachyonychia due to a keratin 17 mutation. Instead, electron microscopy show clearly increased separation of cells. Mal-Dimeleda. Dermatosis is inherited in an autosomal recessive manner. Keratoderma is caused by biallelic mutation in the ARS gene located on chromosome 8q24.3, encoding the SLURP1 protein. The SLURP1 gene is localized in the granular layer of the epidermis and acts as a proapoptotic protein. SLURP1 protein binds through nicotinic acetylcholine receptor to keratinocytes and leads to a decrease in the number of these cells. Accordingly, the mutation of the gene encoding this protein in Millet's keratoderma leads to violation of its function, the regulation of keratinocyte apoptosis chains, and hyperkeratosis occurs. The presence of chronic inflammatory infiltrate can be explained by another function of the SLURP1 protein. It is thought to inhibit the release of tumor necrotic factor alpha by macrophages and keratinocytes. Due to the lack of functional SLURP1 protein, the process is not properly regulated. The release of tumor necrotic factor alpha in the epidermis ultimately leads to the chemotaxis of dendritic and memory cells that support inflammation. It is characterized by thick yellow, brown honey layers with deep cracks. Along the periphery of the lesion, a violet lilac border is visible, several millimeters wide. Pronounced local hyperhidrosis. As a result, the lesions are moist with black dots, excretory ducts of the sweat glands. Hyperkeratosis of the palms and sole passes to the back surface of the hands and feet, forearms and lower legs. There is keratosis in the area of the elbow and knee joints, nails thickened and deformed. Keratosis, hereditary, transgradient and progradient, as a rare form of keratoderma with an estimated prevalence of 1 to 100,000. On the slide, you could see the clinical feature of mal de Meleda. You could see the diffuse hyperkeratosis of the palms and soles. On the slide, you could see the clinical feature of mal de Meleda. Especially, you could see the hyperkeratotic, crippling palmo-plantar keratoderma with multiple constriction, with nail dystrophy. Also, you could see the deformation of finger of the soles and palms. There was a significant improvement in the course of keratoderma 6 weeks after treatment with acitretin 2 mg per kilogram day. For the first time, this disease became known from the Dubrovnik, Dr. Luca Stulic, who described it in the Italian journal Ontology in 1826. He observed keratoderma in a number of his island patients, described it as unnatural skin structure. The non-contagious hereditary skin disease was named mal de Meleda, after the island of Meleda in the Adriatic Sea. The island was used for hundreds of years as isolator for plague and leprosy patients, which contributed to the creation of conditions for consanguinity. Histologically, the epidermis revealed hyperkeratosis, sometimes acanthosis, without sign of epidermolysis. Parakeratosis may be observed, and cases have been described with a characteristic pattern of hypergranulosis. In the papillary dermis, there is a small chronic inflammatory infiltrate of lymphocytes and histiocytes. Nagashima-type palmo-plantar keratoderma, an autosomal recessively inherited type of keratoderma found mainly in China and Japan, similar to Melet keratoderma, but with a milder phenotype characterized by mildly progressive hyperkeratosis and no mutilation, such as the constriction, contracture, and spontaneous amputation of the finger. It usually presents with perioral erythema with occasional brachiodactyly, nail abnormalities, and lichenoid plaque on the scan. The white spongy appearance of keratosis when exposed to water is a diagnostic criterion. Molecular studies show mutation in the SIRPINKB7 gene encoding the superfamily of serine protease inhibitors, distinguishing it from mal de Meleda. A similar phenotype has also been described in the Bosnian type of palmo-plantar keratoderma and is due to a mutation in the AQP5 gene encoding the water channel protein. Olmsted syndrome. Olmsted syndrome is a rare form of keratoderma characterized by mutilation and perioral plaque rash. In most cases, it is inherited in an autosomal dominant manner. Palmo-plantar keratoderma manifests itself in infancy in the form of foci that are diffuse. Severe mutation, contractures, narrowing and amputation of the fingers occur over time. Other distinguishing features are intense itching, hyperkeratotic plaque around the mouth, nostrils, ear, anogenital region, armpits, neck and groin. The histological feature is characterized by the presence of inflammatory infiltrate with the presence of mast cells. The literature also describes corneal change, alopecia universalis, follicular keratosis, oroleukokeratosis, dental anomalies, and sensory deafness. On this slide, you could see Olmsted syndrome. You could see the clinical feature of palmar keratoderma with contractures. Mutation in the TRPV3 gene vanilloid 3 transient receptor potential have been identified as the cause of the autosomal dominant form of the disease. In the recessive X-linked form of Olmsted syndrome, mutation in the MBTPS2 gene, membrane-bound transcription factor proteins, were found. Interestingly, this latter mutation may explain the overlapping feature with follicular ichthyosis, atrichia, and photosensitivity, and deconvenient follicular keratosis. Mutations in PIRP have recently been identified in patients with Olmsted syndrome. PIRP encodes the P53, P63 tetraspan membrane protein, which function as a component of the desmosome and mediator of apoptosis. In this patient, hair phenotype range from curly blonde hair to alopecia universalis. Greco et al. Investigated the possibility of blocking IGFR activation with the inhibitor erlotinib hydrochloride for the treatment of palmo-plantar keratoderma in patients with Olmsted syndrome due to TRPV3 mutation. This hypothesis is based on the discovery that TRPV3 activation is associated with epidermal growth factor receptor signaling through a transactivation process. Current treatment for Olmsted syndrome consists of emollients, keratolytic, retinoid, or corticosteroids that provide minimal relief from the general condition. Treatment of pain and itching are the determining factor in this syndrome. Complications arise as a result of progressive keratoderma and self-amputation of fingers, which chain patients to a wheelchair. Papillon-Lefèvre syndrome. Keratodermatosis is autosomal recessive inheritance and manifests itself at 2-3 years of age in the form of honey layers that appear on the palms and soles, sometimes spreading to the back surface of the hands and feet, the area of the knee joint. Dermatosis is also characterized by the presence of periodontal disease with a tendency to both skin and systemic infection, along the erythematous squamous lesion of the palms and soles. There are phenomena of hyperhidrosis, dental anomalies, and caries. Psoriasis-form rashes appear in the region of the Achilles tendons, large joints. Often there is a lag in the mental and physical development. Skin and dental change usually occur simultaneously, but sometimes dental anomalies develop much earlier than keratoderma. Among the signs, patients had osteoporosis, intracranial calcification, hypertension, hyperglycemia, and enlarged thyroid gland and arachnodactyly. On this slide, you could see the Papillon-Lefèvre syndrome. Especially, you could see the dental anomalies, gingivitis, and periodontitis. On this slide, you could see the palmo-plantar keratoderma and distinct pattern of skin furrows of the Papillon-Lefèvre syndrome. Mutilating keratoderma, Fonvinkel syndrome. This dermatosis is inherited in an autosomal dominant manner. It develops in the second year of life. It's characterized by diffuse honey layers on the skin of the palm and soles and hyperhidrosis. The pathological process gradually leads to the formation of cord-like grooves on the finger, contracture, and spontaneous amputation of the fingers. On the back surface of the hand, as well as in the area of the elbow and knee joint, follicular keratosis, as expressed. Nail plates like watch glasses. Patients often have hypogonadism, hearing loss, cicatricial, alopecia, pachyonychia, the presence of periarticular nevi. On this slide you could see the Fonvinkel syndrome. Especially, you could see the appearance of cord-like groove on the fingers and soles that leads to amputation of fingers. On this slide you could see the pathological feature of Fonvinkel syndrome. Histological examination reveals pronounced hyperkeratosis, granulosis, acanthosis, small inflammatory infiltrate in the upper layer of the dermis. Richner-Hanhart syndrome, tyrosinemia type 2, autosomal recessive hereditary symptom complex, tyrosinemia type 2 caused by mutation in the tyrosine aminotransferase gene in the 16 Q22.1 Q22.3 region. Hydroxyphenyl pyruvic acid as elevated in urine and serum tyrosine as elevated as a result of a defect of tyrosine aminotransferase. In addition to palmo-plantar keratosis, no hyperhidrosis occurs. The disease is characterized by a large in physical and mental development, congenital cataract, underdevelopment of the facial skeleton, and folded tongue. On this slide you could see the clinical feature of Richner-Hanhart syndrome. Especially you could see the hyperkeratotic plaque over soles and central corneal clouding of the eye. Keratitis is an ocular manifestation, but not all patients have corneal involvement. Symptoms include photophobia, pain, tearing, and redness that may appear as early as 1 year of age. Corneal neovascularization, ulceration, and scarring can lead to reduced visual acuity, along with thickening of the conjunctiva, linear and stellate corneal opacities in the epithelium resembling dendritis, pseudo-dendritic keratitis are described. Corneal lesions don't stand. The epithelium of the conjunctiva, fibrosities, and endothelial cells of blood vessels contain an accumulation of large inclusion bodies and crystal-like structure of tyrosine. Greither's disease, progressive hereditary keratosis of the extremities. It was first described by a German dermatologist in 1952 by Greither Alois. The disease is inherited in an autosomal dominant manner from infancy. Dermatosis is characterized by the presence of hyperkeratosis of the palm and soles in the form of honey nodules prone to fusion and extending to the back surface of the hand and feet. There is leukokeratosis of the lips, poikilodermia of the face and extremities, small focal pigmentation with atrophy. Nail plates and teeth are not changed. On the slide you could see the palmo-plantar keratoderma extending to the rear of the hands and feet. You could see the leukokeratosis of the lips. Spanlang-Tappeiner syndrome. The disease is characterized by palmo-plantar keratosis in the form of multiple small foci on the palm and flexor surface of the finger, as well as diffuse keratosis on the soles with hyperhidrosis in combination with alopecia, total or focal, and keratitis. In addition, there is a complete or partial four-fingered dermatosis as transmitted in autosomal dominant manner of inheritance. On the slide, you could see the clinical feature of Spanlang-Tappeiner syndrome. You could see the corneal opacity with hyperkeratosis of palms and soles. Howel-Evans syndrome. It is inherited in an autosomal dominant manner. Dermatosis has been linked to a mutation in the RHBGF2 gene, which is located on the long arm of chromosome. At 17q25, the RHBGF2 protein is a member of the intramembranous serine protease. It is thought to play an important role in the epithelial response to injury in the esophagus and skin. RHBGF2 is involved in the regulation of the secretion of several ligands of the epidermal growth factor receptor. It was first described in 1958. There are two variants of its development. At the age of up to 1 year in the form of diffuse keratoderma. Second, at the age of from 5 to 15 years in the form of islet keratoderma. The variant of keratoderma is combined with adenocarcinoma of the esophagus, which usually develop in the fourth or fifth decade of life. Bazex syndrome. Bazex syndrome, psoriasiform acrokeratosis, is characterized by psoriasiform hyperkeratotic skin lesion in cancer of the upper respiratory tract and upper gastrointestinal tract. The disease is rare, predominantly in men of Caucasian origin over the age of 40 years. In the pathogenesis of the syndrome, alcohol abuse and smoking are considered. Endocrine, metabolic, and immunological disorders. The clinical picture of the disease: psoriasiform, scaly spotted, itchy rashes on the tip of the finger and toes, nose, auricles, sometimes on the palms and soles. The syndrome is also characterized by basal cell nevi or basal cell nevoid carcinomas. Hypotrichosis. Some patients with Bazex syndrome have pigmented small spots, hyperhidrosis, subungual hyperkeratosis, change in the nail plate, milia, keratosis pilaris, tortuous hair, and other abnormalities. This symptomatology is combined with neoplasia of the esophagus, pharynx, larynx, bronchi, lung, as well as cancer metastases in the cervical and mediastinal lymph nodes. Skin lesion regress when the tumor is removed and resume when it recurs or metastasizes. Bushke-Fischer disseminated pinpoint keratoderma. Dermatosis was first described by Bushke and Fischer in 1910. Brouwer confirmed the hereditary nature of the disease in 1912. It is an autosomal dominant inheritance and manifests itself in adolescence. On the skin of the palms, soles, fingers, small intracorneal pearls appear, turning into dense honey brown plaques up to 1 centimeter in diameter with crater-like edge. The lesions don't merge. After rejection of plaques, crater-shaped depression with honey walls remain. Sweating is not disturbed. It should be noted that cases of the disease are described in combination with lymphogranulomatosis and cancer of the internal organs. On this slide you could see the clinical feature of Bushke-Fischer keratoderma. On the first slide you could see the multiple, discrete, punctate, hyperkeratotic, crater-like papules of various sizes on the soles. On the second slide you could see the pinpoint palmo-plantar keratoderma of the palms. On this slide, you could see the specific pathology of Bushke-Fischer keratoderma. You could see the hypergranulosis and acanthosis of epidermis. Acrokeratoelastoidosis Costa. Acrokeratoelastoidosis, described by Costa in 1953. The disease occurs only in women aged of 18 to 20 years, characterized by the appearance on the hands, especially flexor surface of the fingers, palms, and feet of multiple located in group of honey oval or polygonal papules up to 3 mm in diameter with a rough surface and of yellowish white impression in the center. The elements almost do not rise at the level of the skin. They are more likely to be felt than seen. Diascopy reveals the yellowness of the element. Hyperhidrosis of the palms and soles was revealed. On this slide, you could see the clinical feature of Acrokeratoelastoidosis Costa. Especially, you could see the specific hyperkeratosis in the soles. On this slide, you could see the specific pathophysiological feature of Acrokeratoelastoidosis Costa. Especially, you could see the specific hyperkeratosis with acanthosis. Staining by Verhoef van Gizon, you could see the fragmented, thin, elastic fibers, original magnification 400. Keratodermia circumscripta Brunner Franciscece. Dermatosis is presumably autosomal recessive genesis, begin in childhood. Clinically, the disease is characterized by the appearance of hyperkeratotic foci on the areas of the skin subjected to pressure, soles, finger, palm, possible phenomena of onychodystrophy, oral mucosal leukoplakia, scrotal tongue, in some patients corneal dystrophy, oligophrenia. On this slide, you could see the clinical feature of keratodermia circumscripta Brunner Franciscece. Especially, you could see the limited foci of hyperkeratosis on the sole and finger of wrist. Treatment of keratoderma. Treatment of keratoderma as palliative. Neotegazone is indicated in the general therapy of keratoderma. The dosage of the drug depends on the severity of the process and is 0.3 to 1 mg per kilogram of the patient weight for several months of treatment. In the absence of neotegazone, vitamin A is recommended at a dose of 100 to 300,000 mg per day for a long time. External therapy consists in the use of ointment with aromatic retinoid, keratolytic and steroid agents. Physiotherapeutic procedures are useful. Ultraphosphoresis of vitamin A and I cryotherapy. There is some information about the effectiveness of helium, neon, and carbon dioxide laser in the treatment of keratoderma. References. Thank you for attention.